forum started by Professor Dr. Ramakrishna Paramhamsa. He is a professor and HOD of GSL Medical College, AP. Sir has been doing this since nearly last 10 years, 7 years at the state level and 3 years at the national level. And today's discussant being the very well-known professor and director of KKTCH Chennai, Dr. S. Balasubramaniam. I myself as a student have attended so many of his classes. The way he explains things is wonderful. And today's presenter being Dr. Layasvi Datta. She is a postgraduate under Dr. Ramakrishna Paramhamsa sir from the GSL Medical College, AP. So today, I think it's a very important day because for this case files we have our very own national president, Dr. Neela Mohan ma'am. Welcome to you, ma'am, and thanks for being with us on a busy Monday. Usually Mondays is a busy day for all of us. And we also have our past president, Dr. Upendra sir, a very well-known academician. And we have our beloved HSG, Dr. Ruchira ma'am. Welcome. And also welcome to all the other EB members and the state and national OBs. So I think without much ado, we will start today's program. Sir, if you are ready, Dr. Ramakrishna sir, shall we go ahead?
Swati, a word from Dr. President Neelam ma'am, if she wants to contribute.
Okay. Ma'am, would you like to speak a few words?
No, I think that's what we've decided, that we will not spend any time.
Yeah.
Thank you, ma'am. Thank you so much. Thank you so much.
It's but it's so nice for you to be with us, ma'am, today. We're very happy.
Bala is there here.
Yeah, Dr. Bala sir, welcome again. Over to you, Dr. Ramakrishna sir.
Ramakrishna, you're muted.
Right, ma'am. Welcome all, especially our National President, Dr. Neela Mohan, Star of the Day, Dr. Balasubramanian, and all the luminaries. We are privileged to have so many luminaries on the screen and the platform. And thank you for attending. And we invite inputs from you. And one announcement, I encourage postgraduates to send me their interest. I'll be writing my phone number in the chat box. Whoever is interested in presenting cases on this platform, I'll try to provide the opportunity. And Dr. Bala, shall we go ahead?
Yes, please.
Dr. Bala.
Please go ahead. Please go ahead.
Okay. Dr. Lasya, share your screen.
Good evening, sir. Good evening, ma'am. Good evening, respected professor. Myself, Lasasvi Datta. I am finally a postgraduate. My moderator is Dr. Ramakrishna Paramhamsa, sir, professor and HOD of Department of Pediatrics from JSL Medical College from Andhra Pradesh. I wish to discuss topic about a young heart and a old foal. Let's dive into topic. 10-year-old female bought from Rajahmundry, informant being hostel warden who is not reliable. Came with chief complaints of fever for 10 days, pain and swelling of right ankle joint on day 4 of illness lasting for 3 days, pain and swelling of right wrist joint on day 7 of illness lasting for 3 days, cough and breathlessness from day 8 of illness, and extreme weakness from day 9 of illness. History of presenting illness. Came with complaint of fever which has started as low grade, progressed to moderate grade for last 10 days, intermittent in nature, not associated with chills or wriggles. No diurnal variation. Fever is relieved by medication, partially relieved by medication, and child is not dull during interfebrile period. On day 4 of illness, child has pain and swelling in right ankle joint. Swelling which is
Admin, please mute others.
Saji, please mute everyone.
Shall I continue?
Saji, just please keep only 3 of them active. Bala sir, Ramakrishna sir, and Yashasvi.
On day 4 of illness, child had pain and swelling in right ankle joint, swelling which is gradual in onset. Pain was throbbing type. Pain was excruciating and aggravated on movements and partially relieved on taking medication but not relieved on rest. Pain has subsided after 72 hours. Restrictions of movements present. On day 7 of illness, child developed pain in right wrist joint, gradually in onset, continuous and throbbing type of pain. Pain is aggravated on holding things and relieved partially on taking medication but not on rest. Pain subsided after 3 days. No history of small joint involvement or morning stiffness. Complaint of cough for past 2 days, dry cough, on and off, aggravated on supine position. Complaint of breathlessness for past 2 days, exertional, class 2, NIHA classification, grade. Aggravated on doing ordinary activities and reduced on taking rest. No history suggestive of orthopnea or paroxysmal nocturnal dyspnea. No chest pain, no palpitations. Complaint of extreme weakness from day 8 of illness. History of decreased urine output for 2 days. Facial puffiness for 2 days. History of swelling of lower limbs up to 1 inch above the ankle joint. No history of recurrent or chronic cough. No history of hemoptysis. No history of abnormal or involuntary movements. No history of rash. Past history. No history of similar complaints in the past. No history of recurrent joint pains or swellings. No history of previous hospital admissions. No
Just hold
history
on. Just hold on.
Yes, sir.
Last Yashasvi, just hold
Yes.
on.
Yes, sir.
Just hold on. Dr. Bala. Dr. Bala, your comments on history of present illness.
Okay. Nice presentation, Dr. Yashasvi.
Yes, sir. Thank you.
Very detailed and very appropriate and relevant history you got.
Yes, sir.
But people like Ramakrishna and me, we always believe anything can be better than this. Okay, you have done a very good job. Let us try to dissect this and improve upon the information that we are going to get from this history.
Yes.
Rather long history, excellent history. Please go to the first slide.
Yes.
Yeah. Actually, there are 4 complaints that
Yes.
you have mentioned. I would say 5 complaints, because I would put the
Yes, sir.
complaint 2 and 3 into, one complaint.
Yes, sir.
Okay. And 3 and 4 complaints are there.
Yes, sir.
So if I were you, I would have only, my suggestion is always, the examiner's attention span is always very poor. So he would forget. So what you should see and ensure is to catch the attention of the listener, whoever it is, whether it's an examiner or whether it's your boss, somebody like Dr. Ramakrishna. So I would have probably put it as fever 10 days, multiple joint swelling starting for over a week,
Yes, sir.
cough and breathlessness the
Yes.
last 2 days, and
Yes.
extreme weakness from yesterday. Okay, that's how that would have been more appropriate rather than otherwise it's fine. Please go to the next slide. So there are 4 complaints. Now, one of the important things PGs forget to do in the history of present illness is to make it clear when the illness started, when the illness started. So you have said that fever had started, but you had not made a mention of how this child was before the onset of illness. Do you think that is important or not important?
Importance.
In what way it is important?
So we could assess whether any infection previously has been present or not, or
To
child.
time the events, okay?
Yes.
If I were you, I would have perhaps asked for more information from the parents whether she was absolutely well 10 days back. Do you think it is important or not important?
Yes, sir, it is important.
Yeah, because that would have ruled out something more chronic than what it is
Yes.
right now.
Yes.
Second, it would also ruled out recurrent problems.
Yes, sir.
Third, you would also come to know whether this child was previously healthy or not. So if I were you, I would have probably asked more questions to the parents about how she was 10 days back. In fact, what do you expect a 10-year-old normal child to do? Can you tell me what you expect a normal 10-year-old girl to do?
Actually, I would have asked, sir, but informant being hostel warden, sir, she stays in hostel.
No. How you think a 10-year-old girl won't tell you that she's going to school, she's cycling,
Yes, sir.
she's running, playing?
Yes, sir.
Is she
But
is she deaf and dumb? No.
no, sir. No, sir.
Then why do you require a hostel warden? 10-year-old child will give probably a better history than the warden or even the parents.
Yes, sir.
Don't mistake me. See, after all,
No, sir.
you must see simple questions like whether she was going to school. Even the warden will tell you whether she was going to school. She was going about normal exercise, play, etc. Right? Whether she was cycling, whether she was running, playing, etc. To make sure that the entire problem started only 10 days back. Don't you think it's important?
Yes, sir.
Yeah, that is one.
Yes.
Second, few questions I'm going to ask you. Why did you ask for diurnal variation? What's the importance of diurnal variation in fever? You said there is no diurnal variation. I'm surprised. I'll tell you why I'm surprised. Can anybody put in the chat box what is the importance of diurnal variation of fever? Okay, let me put it very clearly. All fevers of chronic duration, the fever will be more toward the evening. Probably it is nature's creation to help pediatricians in practice. So only in the evening the fever will touch 404. They'll come to you. Right? It's a normal circadian rhythm. Right? It goes up in the evening. In fact, the old textbooks of medicine used to say that the circadian rhythm can get reversed in miliary TB. Okay, that's normal. Any fever is likely to be more toward the evening, right? So that is one. Second, you have also mentioned that fever is relieved by medication. Why did you mention that? What is the significance of, there are says the same child, the girl says, even if I am given medication, the fever did not go. How does it differ?
It could be
Pardon?
like
Actually,
severe infections like typhoid.
Which medication? Do you think one dose of medicine
Hear the
work
question.
in typhoid?
Sir?
Do you think one dose of medicine will make a difference to anybody with typhoid of 7 days, 8 days? Nothing will happen.
No,
You
sir.
will come back promptly. It will take 4 or 5 days. In fact, if one dose of medicine, the fever disappears, it's not typhoid.
Yes.
Okay, just to tell you one fundamental fact again, of course, not in a 10-year-old child, but I can tell you if it is an infant with fever without focus, there is a fundamental fact people often forget. The fact is that whether the fever is due to something like a benign viral infection or whether it is due to pneumonia, UTI, or meningitis, your paracetamol or ibuprofen might work nearly equally. prompt response to antipyretic medication alone is not enough to distinguish a benign viral infection from a serious bacterial infection.
Yes.
Only difference is that in a serious bacterial infection, the infant or the young child will not behave normally during the interfebrile period. That's all. So because the fever comes down, it doesn't rule out meningitis. That is a fundamental point. So I don't think relief by medication is meaningful at all in a 10 days fever, except maybe if you say you had given an NSAIDs and the fever had completely disappeared, then perhaps an anti-inflammatory action and an inflammatory disease as a diagnosis is possible. Okay, next comment. I always advise postgraduates not to use the term dull. If you go to the English dictionary, the term dull means it means somebody is intellectually bad. So it's incorrect. It's an insult to any child. Please do not say lethargic. Was not lethargic or tired during interfebrile period. That's what you should. Don't use the term dull. If the mother knows good English, she will object to the use of the term dull. If you tell the mother child is dull.
Yes.
Okay. Next, you had mentioned is the pain in the right ankle joint. Okay. You had
Yes.
mentioned a few things. One, it is throbbing in type. What is the significance of throbbing?
Means
What throbs? You tell what throbs?
Sir,
Throbbing.
What throbs? Okay.
Okay. Actually, the inflammatory pain is not throbbing. It is usually continuous. Throbbing indicates that it may be something like a vasculitis. Okay. But not, I don't know what you meant by throbbing of the joint. You don't see that in the joint. Okay. Agreed that the movements are aggravated on movements and partially relieved on taking medication, but not relieved on rest. Now, I'm going to ask you a very significant question, because this is not related to this case. There are two children with joint pain.
yes.
One child says the movement after vigorous movements and exercise, the pain comes down. Another child says movements and exercise increase my pain. What is the difference between the two? Anybody can put in the chat box. Very simple. Any degenerative arthritis, for example, if I have a hip pain and if I walk for about half an hour, the pain will disappear. Any degenerative joint pain may actually improve with exercise, whereas if it's an inflammatory pain, it will always worsen with exercise. Okay, right. And one question you should have asked about pain is whether the pain was there during sleep. Is that important? Or pain was more during sleep? What's the importance of nocturnal pain? Again, nocturnal pain of the joints indicate that the pain is likely to be organic and not non-organic. Okay. Second, nocturnal pain is notoriously more in inflammation like your rheumatic or rheumatoid arthritis, and also in malignancies, bone pain, and in osteoporosis. Okay, right. And pain had subsided within 72 hours. Was she given some medicine? What medicine was given? Did you ask that?
She
Look,
had
the problem is the girl is an orphan girl, sir.
Okay.
And nobody is to give any information. That's the
Okay.
problem.
Fine. It's
Whatever
okay.
the girl
No,
say, we
I
have to hear. And she is a tribal girl. She
agree.
doesn't have any expression also.
Agreed. I know it's not a perfect situation. Right. Restriction of movements is present. Please go to the next slide.
To the extension of Dr. SBS told, the pain at night is a red herring sign and it is due to periarthritis, and you have to be very careful. It may be indicative of leukemia. An extension what he is told. Right.
Okay. Then on day 7, she developed pain, and then you didn't mention whether there was swelling. You only mentioned right wrist pain. Was there swelling? Yes or no?
no, sir. On day
No swelling.
7, witness, there
Okay.
is no
Okay. It looks
swelling.
like an inflammatory arthritis of the wrist. and no history of small joints or morning stiffness. Okay, fair enough. And okay, fine. Were there any other joints which are involved?
No, sir.
No.
Only
Okay,
two joints.
fine. Okay, fair enough. Cough, dry cough, okay. Breathlessness, New York Heart Association class 2. One thing I wanted to tell you,
Yes.
how commonly you have seen paroxysmal nocturnal dyspnea in pediatrics? Is extremely uncommon. There are two things in pediatrics which in cardiology are rare. One is paroxysmal nocturnal dyspnea. It's purely an adult problem. Extremely rare. Second thing is hemoptysis. Again, you asked for hemoptysis. I saw in the next slide. Both are very, very uncommon. It's a sign of, your left ventricular failure or mitral stenosis causing right heart failure. Okay, left sided failure. Okay, chest pain, palpitations. Okay, next slide. Okay, now extreme weakness. Okay, you had mentioned extreme weakness. What are the conditions you will think of when somebody is brought with extreme complaint of extreme weakness? What do you think is the cause for extreme weakness in this child on day 8?
Low cardiac output. Like
Low cardiac output, one. Is there any other cause for low, very extreme weakness, as you have put it, other than cardiac?
inflammation.
Pardon?
Inflammation.
Inflammation will not produce extreme weakness. No.
Issue at the box.
Other than cardiac.
Severe anemia.
Okay, very good. Any blood loss, any anemia, hypotension, circulatory failure, hypoglycemia,
Yes.
dehydration,
Yes.
hypoxia.
Yes.
Okay, somebody has put correctly in the chat box, hypoglycemia, even hyponatremia, can cause fatigue. In fact, many adults who get fatigue, one of the most common causes you pick up is a low sodium. You correct the sodium, complete normalcy will come, other than hypoglycemia, right? Okay, decreased urine output. It may be because of with exertional dyspnea, there is a possibility that there may be a cardiac failure resulting in decreased cardiac output causing extreme weakness. I agree with your statement. Then history of decreased urine output for 2 days, facial puffiness, okay, swelling of lower limbs, okay, indicating edema. She is developing anasarca. Okay, no history of. Why did you ask for history of recurrent or chronic cough?
Actually, any previous history to rule out the infective conditions or primary deficiencies.
Pardon? No. What made you ask
Doctor.
if recurrent cough or chronic cough? I wouldn't have asked probably in this case. If you had mentioned that she was completely normal, I wouldn't have asked. What's the significance? What did you aim to get?
Like ruling out, like she
Ruling out what?
he
What?
being
TB.
is
Do you think TB will present like arthritis and
no, sir.
cardiac
Like,
failure and this sort of fatigue and all that? Very, very. I mean,
like
it's not relevant.
chronic cardiac disease.
Again, hemoptysis in 10 days history, no, absolutely no. Somebody has put pulmonary congestion. The whole history is only 10 days. You have said previously she was normal. I wouldn't have asked anything. Of course, the abnormal involuntary movements, chorea probably you entered. Rash. Okay, rash in this child. What are the rashes you would have? What are the conditions which will make you connect to the etiology where there is rash?
Eczema, like viral exanthemas will have rash, sir. In this here we can see that erythema marginatum.
Okay,
I mean,
one is erythema marginatum if you are thinking of rheumatic. Other than that,
viral myocarditis, like
viral myocarditis, okay, I concede, but
yes.
arthritis is very, very unusual. Okay, still can occur. Agreed. Then,
Any allergic hypersensitivity or like infective conditions, like if she presents in decreased urine output, like dengue.
so suppose the mother says that the rash or the warden says when the fever is 104, rashes used to appear and go off. Is that significant?
Yes.
What is it? What does it signify?
Like in dengue fever or typhoid.
Dengue, no.
Typhoid.
Can anybody put in the chat box? Rash at the height of fever. You give paracetamol. By the time you give paracetamol, fever comes down, the rash would disappear.
In
What's the diagnosis?
inflammatory conditions.
Child with arthritis. Oh, somebody has.
Juvenile
Yes,
idiopathic.
Dr. Vijay Lakshmi has put correctly in the chat box.
Systemic JIA.
Systemic onset juvenile idiopathic arthritis. In fact, in no other condition, that sort of transient or evanescent rash appearing in the extremities at the height of fever, without itching, and with prompt disappearance of fever, it is very, very characteristic of JA. In fact, I had the opportunity to diagnose at least 3 or 4 cases only with that history. Only with the history. You don't require even investigations if the history is like that. Of course, somebody has put in the chat box rickettsial infections. Agreed. Okay. But then you will get rashes in the palms and soles, petechiae, etc. Okay. Rashes, you should think of SLE. Agreed. Should think of exanthems, etc. Agreed. You should even think of henox-condyline purpura if there is arthritis with rash. Agreed. Please go to the next slide. Yeah. Past history, no similar complaints. Okay. No history of previous hospital admission, no history of usage of medication. In fact, in the past history, you could have, one sentence would have been very useful. She was a previously healthy child. That gives a lot of information to you that the whole thing had started only 2 weeks back. Okay, please go ahead. But of course, I concede she's in the hostel. Next slide. Yeah, antenatal history. Milestones have been normal. Immunization doesn't. Okay, fine, doesn't matter. Next slide. Dietary history. I don't think I would worry too much, except that rarely you can have something like severe iron deficiency anemia, causing cardiac failure. You can probably elicit improper diet, etc., or by beriberi causing cardiac failure, thiamine deficiency, etc. And doesn't look like that. Okay, next. Don't worry about the dietary history in this case. I'm not going to spend time on it. She's in the hostel. She must be getting probably good calories and proteins, I assume. Okay, go ahead.
Family
Please go ahead.
history.
Sir, Dr. Ramakrishna, you want to add anything at any time, please add.
Yes, sir. Go to history of present illness, last session.
Feel free to add, sir.
Okay. Right, sir. And the pain must be excruciating. Fever in such scenario, so it will be so excruciating. Even the movement of the bedsheet also causes severe pain. Okay. And the pain, do you think it is subsided on its own, or it has subsided because of your anti-analgesic treatment or anti-inflammatory treatment?
I think it subsided on its own.
Such excruciating pain is unlikely to be relieved with 2-3 days of anti-inflammatory analgesic treatment. Right. Next. So it must be spontaneous relief.
Spontaneous reliefs.
Next. Restriction of movement, you may elicit whether it is for active movements or passive movements. In this case, for both.
Yes.
So what do you call this type of joint pain? Initially started in one joint. By the time it relieved, it has gone to the next joint. Do you call it as?
Migratory polyarthritis. Fleeting type of polyarthritis.
Be cool and calm. Right.
Fleeting type of polyarthritis. Right. Like one joint.
Migrating. What is the signal? What are all the possibilities of for the cough to occur on day 8? What does it suggest? It's an important pointer.
Maybe.
Just a minute. I encourage at least the postgraduates to either unmute and answer or push their answers in the chat box. Dr. Neelam Mohan has given us the Zoom link to facilitate interaction. Without there being interaction, this cannot be called as a clinical case discussion, right? Doesn't matter even if it is wrong. What is it's a red herring symptom. What it may convey.
Child is going into like a pulmonary congestion may be present, sir, due to left heart.
Right, you are right, and Dr. Tejaswini also is right. So it is unlikely to be because of respiratory tract infection, because there is nothing suggestive of respiratory involvement. So far, the fever has started some 10 days back, and on day 8 or 9, the cough appearing with history of exertional dyspnea. The first possibility goes to pulmonary congestion, because we have to rule out the more important critical conditions, right? And history of breathlessness suggests that it is involvement of which system again? It's a short history of this much with exertional dyspnea. You think of like with joint pains, we are likely it is cardiovascular involvement. And do you expect in such short history paroxysmal nocturnal dyspnea? Yes, it can occur whenever the decompensation is quick. The left ventricle is the one, that left heart is the one which is affected most. So in this child, there is a possibility of there being paroxysmal nocturnal dyspnea. What does it indicate? Orthopnea or paroxysmal dyspnea again indicate there is increase in the pressure in which chamber? Left chambers,
Left
that back
chamber
pressure in the
pressure, back
pulmonary
pressure,
circulation. Right.
pulmonary
If
congestion.
there is chest pain in this scenario, what it can mean? Whenever you are asking a question, you should know what is the relevance.
It could be
Uh-huh.
pericarditis.
One is pericarditis. Good. What else? There is quick degradation in the heart function. It can be angina even. Angina. It's very unusual in children, but angina can occur and it may present with chest pain. What else? Anybody? And what does palpitation signify?
Tachycardia.
More than that, whenever the left ventricular output is large quantity associated with some hypertrophy, it results in palpitations. So, if there is chest pain, rule out angina. It can occur in the acute left ventricular decompensation. And pericarditis, of course, there is no specific treatment required in this scenario separately for it. And palpitations gives the clue what is the cardiac output probably, right? Next. The previous one. Extreme weakness, otherwise called as EG fatigability. Again, EG fatigability in this backdrop, that is suggestive of
Acute
hypoxia in the peripheries. It can be, as you said, it can be because of the decreased perfusion to the tissue, either by way of low blood supply or because of severe anemia, that is low oxygen carrying capacity. It's again a red herring sign, okay, or symptom. And history of decrease suggestive of probably there is decrease. It is maybe secondary to the some cardiac decompensation because there is patient puffiness and bilateral pedal edema. Right. Okay. History of rash, joint pains, exertional dyspnea, rash. What the rash can be in this scenario?
Erythema marginatum could be present, sir.
You are right, but you talk loudly.
Yes,
right.
sir.
Dr. Harshal wants you to speak loudly. I also am incidentally telling. Be confident, be assertive, speak loudly, come close to the mic. Thank you, Dr. Harshal. Right.
Yes.
Next. It can be erythema marginatum. Okay, do you expect in such scenario, which are the conditions which appear along with fever, which don't appear along with fever? You'd like to answer later? Okay. Remind me and answer this question later. Which are the findings which may occur along with the appearance of the fever, which occur a little later? You remind me and you answer that question later. Right. Next.
Like with fever, it could be carditis and.
You complete the history, Dr. Leslie. Go ahead.
Complete. You will go later. That's what I'm telling.
Yeah.
No, personal history. Go back.
The personal history. Yeah, complete. Anything relevant? Okay. How many children in the family? nationality, socioeconomic status, those things I would like to know. Okay, fine. Inesh is in the hostel. You
It's
must
a single child born to non-consanguineous marriage, sir. There is no history of similar complaints in the family, no history of heart disease in the family, sir. There is no history of contact with tuberculosis in the family. Mother is a known case of epilepsy, sir.
Okay, in the
This is in
past
family
history.
history of 3 generations. Yes.
Okay. Personal history, socioeconomic status, okay, fine. Your history is complete?
Yes.
Yeah. Now I'm going to ask you what past history, which is very, very important and significant in this girl, which you forgot to mention. Can anybody put in the chat box?
I should have asked if she was when healthy previously before 10 days or not.
That is one. And Tejaswini has put rightly history of sore throat.
I have asked.
Sore throat. History of sore throat. Is that important?
No history of throat infection.
You mentioned, did you?
No, she didn't mention. No history of throat infections. Okay. Other than throat infection, what other history would have been relevant in this patient? Anybody can put in the chat box?
Skin infections.
Okay. Of course, this is what is it? Previous episodes of rheumatic fever. Correct. Previous episodes of fever with arthritis. Good. Anything else? Two other things I would have asked for. Even though it is only arthritis, but this child has developed cardiac failure, I would have asked for some dental caries or any dental surgical procedure in the recent past. 1. 2, this is new data. Digis may not be aware. Even in cases of rheumatic fever, you should ask for not only history of sore throat, but you should also ask for history of pyoderma. In fact, there are studies which have shown that even the strains causing pyoderma may be responsible for rheumatic fever. This was not the concept which was there 30 years back. Now there is a nice paper from Lancet, which with a review of rheumatic fever, in which it is clearly mentioned that in New Zealand they have reported girls and children having pyoderma going on to develop rheumatic fever. So please ask for history of pyoderma also from today in cases of suspected rheumatic fever. That's new data for you. Okay, please go ahead.
Last year, haven't you mentioned?
But Lancet,
Have you mentioned or not?
Lancet is mentioned. It's a review.
No. Has she mentioned? I'm asking. Right. Anyway, Dr. Kiran Bundu rightly answered. It is skin infections. Right.
Skin infection is important. Yeah, good. Sum up your history.
A 10-year-old girl born of a non-consanguineous marriage via LSCS, full-term, birth weight of 3.5 kgs. Immunization is not up to date as per a national immunization schedule. Developmental history is normal with calorie deficit of 9.3% and protein deficit of 7% presented to OPD. With fever for 10 days, joint pain and swelling of right ankle joint on day 4 of illness, lasting for 3 days. Joint pain and swelling of right wrist joint on day 7 of illness, lasting for 3 days. Cough and breathlessness in NIHA class 2 from day 8 of illness and extreme weakness from day 9 of illness with history of swelling of feet for 3 days. Pain in right ankle joint associated with swelling was gradual in onset and migratory from ankle to wrist joint, continuous and throbbing type of pains.
See, two things. When you sum up, you need not give so much of data. Do you think this calorie deficit of 9.3% and 7% of protein deficit is responsible for the disease?
No, sir.
No, it's not relevant. So I don't think you should, give such a long sentence. You should make it a habit to make it brief. Please don't mistake me. As I said, the attention span of the examiner is always short.
Yes.
Right? They will think that you have not mentioned so many things. Okay. Instead of saying throbbing and all that, you say arthritis. You have come to a conclusion that it is arthritis from the history.
Yes.
Right? And it is not monoarthritis, it is polyarthritis. Again, it is migratory polyarthritis. One sentence, you could have summed up the whole thing.
Yes.
Yeah. Go to the next.
Anthropometric.
What is the diagnosis at the end of the history? always, before you go to the physical examination, you must have some provisional diagnosis. Then only, in fact, only recently I went through the net. There is a nice article in British Medical Journal, 1970s, where they analyzed cases, the diagnosis of clinical problems based on history plus physical examination, based on history plus physical examination, and investigations. And to their surprise, it was noted that in at least 2/3 to 3/4 of cases, history alone was right in giving the final diagnosis. Only in 15% physical examination added to the diagnosis. Only in another 7 or 8% investigations came to the rescue. Even in India, there is an article in Journal of Association of Physicians of India, one Dr. Rao, a physician, published in 2000. Almost similar data. Nearly 70 to 75% of cases, history alone will give the diagnosis. So make it a point to give a probable historical diagnosis before you proceed for examination. Yes, doctor.
Like continues.
Yeah, what do you think is the diagnosis from the history before you proceed for examination?
Probable diagnosis.
My probable diagnosis is it is a case of acute rheumatic fever, sir. I can see that with migratory polyarthritis present, sir, and fever present, sir. And we can see as it is going into cardiac failure. Could involvement of valves present, like carditis present, sir. So it met the two major criteria of carditis and migratory polyarthritis along with fever. So it matches the criteria of
Okay, do you
rheumatic.
think she's got cardiac failure or not?
It could be, sir.
Why you say could be?
I mean,
What is against cardiac failure? You are so defensive.
no, sir.
You dyspnea, exertion, edema, easy fatigability. What more you want for cardiac failure? Okay. And obviously, this is straightforward rheumatic fever with rheumatic carditis, which is severe, causing cardiac failure. You can straight away come to a conclusion with this. Is there any
Yes.
other diagnosis other than rheumatic fever, carditis, cardiac failure in this patient? That's my question to you at the end of history.
No,
What
sir.
other DD will you consider? Can anybody put in the chat box? So JA. No. The answer is no. How often do you get cardiac failure in so JA? No. And that too within 10 days. Absolutely no. So JA is a very chronic disease. Severe anemia can occur only if there is macrophage activation syndrome. You don't get cardiac failure just like that in 10 days. And again, so JA, the age is usually less than what it is in this case. So I wouldn't think of so JA. Okay. And so JA, arthritis will not simply disappear just like that. This arthritis will be persistent, will not be migratory, okay, will be much more severe. I don't think it will respond so well to any drugs. Yes, infective endocarditis. Yes, you have to think of even a native valve endocarditis. Yes. Or you don't know, this girl might have had rheumatic fever earlier, though history is not coming, as given by the warden. She might have suffered from rheumatic fever earlier. She might be having an underlying valve disease. And she on a pre-existing valvular disease, she could have developed endocarditis, infective endocarditis. It can't be ruled out in this patient. Okay? Right. Somebody has put in the chat box. Let me see what it is. Good, I'm seeing responses in the chat box. The chat box, so SAJ arthritis involved wrist joint, age not fitting, rheumatic fever arthritis will respond. Agreed. Okay, fine. Then go ahead for examination. Please go ahead. Dr. Ramakrishna, you want
Just a minute.
more in the history
Yes, yes.
before you go to examination.
Just 1 minute. I invite Dr. Sara ma'am, Dr. Kalpana Datta madam, Dr. Vijayalakshmi madam, and many other professors who are on this platform to give their inputs. We are open to your
Thank you, sir. Thank you.
Right. Okay, ma'am. You want to give some input? Okay.
Sir, if I want to say, first thing on history, it's acute arthritis. So with this is acute arthritis is involving the joint or periarticular tissues. What we know, if it's on a joint involvement, then the pain will be there in the each and every movements. But in case of periarthritis, periarticular parts of the joint, it will be painful only in a particular movement. So that to be asked in the history, because though we very much with that rheumatic origin and rheumatic carditis and arthritis there, but for the beginners they should know the arthritis or it is periarthritis. That is very important. Second is the other joints and involvement. We know the hip joints and the temporomandibular joint. They should ask whether there's any problem in the hip also, or axial joints involvement, because they will go on excluding the other differentials and will likely to land up with the rheumatic fever. So they should not take it granted that it's a rheumatic fever. They will always rule out the other causes. So it is very important to rule out axial joints. Then the temporomandibular joints, the movement while chewing and all, whether the child is feeling pain on that temperamental joints or not. These are the points to be asked along with the arthritis. Then the night cry and all. Is there any pain, the severe in the night and all. These things to be included in the history. And then, of course, other features, because in the history, we would like to do the some differentials, as I said, and then try to establish one diagnosis. When it comes to the diagnosis, we'll try to know how severe it is. What is the progression of disease? So it is progressed to heart failure. That is there. Then,
Yes.
of course, we'll examine anything, other history. And what is it? And as a routine, we ask about the bladder, bowel, sleep, appetite, all those things. There's a routine question in each history. At the end, we should ask all those things. This is from my side, sir. Thank you.
Okay, somebody has put.
Okay, thank you, ma'am.
Bharti has put
Dr.
rheumatic-
Bharti,
Dr. Bharti has put rheumatic fever arthritis will not last more than 7 days. I disagree. It can go on
that's
for
what.
4 to 6 weeks or even 12 weeks sometime. It can keep on going unless you suppress it with NSAIDs or steroids. The arthritis can again go on for, it doesn't go off in 7 days. Again, mycoplasma, mycoplasma, to blame it on arthritis like this with cardiac failure, it is too much. I think the association between mycoplasma and several diseases is an exaggerated one. You don't get polyarthritis and then occasional cough and cold is like this with without skin manifestations. Okay, and you don't get cardiac failure in a patient with mycoplasma. This is, I don't think mycoplasma need to be considered in this patient
Sir,
who doesn't have primarily
I would like,
pneumonia. I don't think you should consider in this patient. Though agreed,
yes, sir.
mycoplasma can cause extra pulmonary manifestations starting from the skin, joint, blood, CNS, and even kidney. Agreed, but are not in this child. Yeah, please move on to the physical
Sir.
examination. Yeah.
Dr. Bharti, the average
Sir, I would like
duration
to
of
ask what are
treat-
the other causes of migratory polyarthritis for the residents?
That's a good question.
One is the rheumatic, and any other causes of migratory polyarthritis? The answers we are expecting from the residents.
type in the chat box.
It could be.
Before that, in the meantime, Dr. Bharti, the average duration is 7 to 10 days. 10 days is not longer. Average duration is 7 to 10 days. In rheumatic fever, the duration of fever and
Yes, one is right.
Could
Lyme
be
disease can cause
viral
migratory
arthritis, ma'am.
arthritis. Huh?
Viral arthritis.
Migratory
be-
arthritis. What are the other causes of migratory arthritis? One, someone has written correctly, that is Lyme disease. Anything else?
Gonococcal arthritis could be this. And viral arthritis could be there, ma'am.
Reactive
and
arthritis also migratory.
Rheumatological diseases like
Yeah.
reactive arthritis.
Yes.
Right.
Early
Okay,
rheumatoid
proceed, Asha.
arthritis also may present.
Loudly, speak loudly and proceed.
Yes, these three is correct. Gonococcal, Lyme disease, and reactive arthritis. These are the causes of migratory arthritis.
Mm.
Thank you.
Dr. Usha Rani is Professor and HOD in Osmania Medical College. Welcome, madam. Right. Proceed. Lasha, proceed.
Yes, sir. Anthropometry, the observed.
No. Wait. I think, don't mistake me, Rasija. Don't start with anthropometry. Physical examination does not start with anthropometry. Physical examination starts with the general appearance and your first impressions of the child. That is what pediatrics is all about.
Yes.
Pediatricians make most of the diagnosis by simply looking at the child and getting the history. You don't require to even touch the patient. So don't start with anthropometry. That's a bad habit. Please don't mistake me, Dr.
Yes, I will correct. I will correct
Exams
it.
don't start
Thank
with anthropometry straight away. Start with the general examination and general appearance before you go into anthropometry, nutritional status, etc. Go ahead.
General examination. Girl is conscious, oriented to time, place, and person. Examined in lying down position with pallor present. Nails are normal. Papillae of tongue are present. No hyperpigmentation of knuckles. SMR staging stage 2. No icterus, no cyanosis, clubbing, lymphadenopathy.
Wait. I think one of the things that modern day postgraduates don't do is to simply look at the child for a minute or two, not even minute, 30 seconds. You simply look at the child and ask the following questions. One, is she well or ill? Second, if she is ill, whether it is acutely ill or whether she is acutely ill or chronically ill. Third, is she comfortable or not? Fourth, are there any alerting or arresting signs which gives me the diagnosis? And then only all this lying down, speaking, interacting, cooperative, conscious, alert, etc. I think this is one habit which must be there, which must be propagated to the postgraduates. You make a habit of describing the child's first impressions, your first impressions on the child. That should be the first sentence, not anemia, jaundice, lymphadenopathy.
Yes.
In this girl, I would have straight away said whether she is ill or well, she is ill-nourished or obese or malnourished, looking thin, or she is fairly nourished, whether she is having any respiratory distress, and so many other things. And whatever, even if in general examination, I see some joint swelling, I would describe in the first sentence. Please make it a habit. Please go ahead.
Yes. Vital data. Pulse 120 beats per minute.
So
Regular
you
rhythm.
answer this before you go to the vital data. I'm not going to leave you. Answer those questions which I was asking. Sorry. Don't get rattled.
Yes.
Don't get upset.
Yes.
Yeah, tell me now. Is she well looking or ill looking?
She is ill looking, sir.
Okay, acutely ill looking or chronically ill looking?
She is on bed rest, sir. She is unable to do daily activities, sir.
Is she chronically ill looking or acutely ill looking?
Acutely ill looking, sir.
Is there any respiratory distress, any dyspnea? She's breathless.
Exertional dyspnea present, sir. Grade 2 NIHA classification.
Okay, is there any edema right on inspection?
Edema.
Okay.
Puffiness of face present, sir, along with edema of
Do you see any joints? Do you see any joint swellings right on inspection in the beginning?
On inspection, there is no
Okay.
joint swelling.
Now
At
go
time
ahead.
of our presentation, there is
Now go ahead with all other findings. Please go ahead.
Yes. Pulse 120 beats per minute, regular rhythm, high volume pulse, bonding type. There is no radial delay or no radiofemoral delay. Carotid, brachial, radial, femoral, popliteal, posterior tibial, and dorsalis pedis pulses were equally palpable. Respiration 40 cycles per minute, regular thoraco-abdominal type. Blood pressure 100 by 30 mmHg in right upper limb and left upper limb in supine position. 120 by 30 mmHg in right and left lower limb in supine position, sir. Saturation is 9.
Wait. What is your Comment on the blood pressure. What is your inference? What clue do you get from that?
There is wide pulse pressure difference, sir. In both upper limbs and lower limbs, there is a wide pulse pressure difference, sir.
If there is wide pulse pressure, what are the conditions you will think of?
Here in this condition, I could think of there is aortic regurgitation, sir. According to history, it could be aortic regurgitation, sir. Or any other heart failure conditions.
Any heart failure, do you
PV
get wide pulse pressure?
Don't. See, actually, it is other way around.
sepsis.
No, you
You
tell
get
what you
narrow
know.
pulse pressure or wide
Sep-
pulse pressure when there is
n-
cardiac
n-
failure.
narrow
narrow
pulse
pressure.
pressure, sir.
Narrow.
Sepsis.
Remember my olden days we used to say A, B, C, D, anemia,
Yes, sir.
very,
Yes.
coarctation of aorta, right?
Yes, sir.
Right? Then
Yes.
you can get in PDA, any,
Yes. Fistula.
any large left-right shunt, even VSD can have a large volume pulse and wide pulse pressure.
Yes.
Truncal sometimes in cyanotic heart disease,
Yes.
right? Okay.
Yes.
Even your AV fistulas, coronary AV fistula, DDF, PDA, okay, aortic regurgitation,
Yes.
all can have wide pulse pressure, including anemia, thyrotoxicosis, beriberi,
Yes.
right? All these are
Yes.
differential diagnosis for a wide pulse pressure. Go ahead.
Yes. Shall I continue with anthropometry, sir?
Please go ahead.
No, you complete it.
I
Complete.
You
complete.
complete it.
Complete.
Saturation of 98 is saturation 98% on room A, CRT 2 seconds, temperature is 99 degrees Fahrenheit.
No, go back.
Head-
Go back. Go
Yes.
back. So, either tachycardia?
Yes, sir.
Yes. Cause for what are the possible causes for tachycardia in this child? In the backdrop of history,
Fever present, sir, but more
okay,
than
fever, common thing. Then
heart failure, it could be a cause.
heart failure, too.
Mm,
In
yeah,
heart failure, the
rheumatic-
pulse pressure is narrow, but you
Yes.
are having high volume, bounding pulse. So
Anemia, it could
there are
be
two
caused
things, anemia. Okay,
palate
there are two things which are acting in opposite direction. Heart failure narrows down the pulse pressure and aortic leak increases the pulse pressure. So the
Yes.
balance is manifesting as increase in the pulse pressure. So
Yes.
the girl may be having both, right? What
Yes.
does the girl have tachypnea?
It's 40 cycles per minute.
There is no respiratory tract
Respiratory.
infection, but still the respiratory rate is on higher side. So what does it indicate?
Yes. Pulmonary congestion maybe.
Okay, right.
Already.
And so what is the repercussion of having 100/30 blood pressure? Low blood pressure, what are the disadvantages the child faces?
In diastolic phase only more perfusion will be there, sir. As cardiac cycle, diastolic phase is more, sir.
Especially to
Coronary
artery.
Yes.
Right. Whenever there is tachycardia, the duration is less. That's why coronary arterial supply will be less. With
Yes.
low pressures, again, it may suffer. Next. In the exams, you are expected to analyze the vital data as well as the anthropometric, not simply reading out. Okay.
Yes.
Quickly.
Head to toe examination. Head is normal in size and shape. Hair is normal. Face is pale and puffy. No facial dysmorphism. Oral cavity, paler present. Tongue papillae present. Dental caries present, sir. Eyes paler present. No interest. No signs of vitamin A deficiency. No nasal flare. Ears, tympanic membrane is normal. Neck, we can see engorged veins, raised JVP, and visible suprasternal pulsation, sir. Chest, there is no precordial bulge or chest abnormality. Abdomen is normal. Spine normal. Umbilicus is normal. Genitalia are normal. Extremity is normal. Skin, there is no rash. No subcutaneous nodules. There are no skeletal deformities.
1 minute. Go back.
Yes.
How did you examine for subcutaneous nodules and where did you examine for subcutaneous nodules?
I have examined the bony prominences, sir, mostly in the elbow regions, and also have examined. But there are no subcutaneous.
Not enough.
Loudly,
I'll
loudly.
just tell you what my professor of cardiology taught me in 1983.
Yes, sir.
Okay. In any child with a suspected cardiac problem, every pediatrician should do two things.
Yes.
Very funny things. She used to say. One, first, before you start the cardiac examination, you should bend down, put your fingers on the dorsalis pedis and pay respects to the patient.
Yes.
Okay, remember this. So bend down, feel the dorsalis pedis so that you do not miss a coarctation of aorta. Number one. Number two, after taking the blessings of the child that you should pass and you should not make mistakes, you must bless the child from head to foot. From here, you should start, run over the occipital prominences, then put your fingers on the mastoid, then over the cervical spines, run over the scapula, then bring it down to the olecranon, extensor aspects of the elbow, then run it over the back of the spine, iliac crest, and then come down right up to the ankle and toes so that you do not miss any subcutaneous nodule.
Yes.
And the reason why you should not miss a subcutaneous nodule without ECG, without echo, without ESR, without ASO,
Yes.
if a nodule is present, that child definitely has carditis. It gives you a clue. It's such a crucial finding, probably more sensitive than even an echo
Yes.
to diagnose carditis.
Yes.
So that's important. So remember to bless the child. Remember also to pay your respects to the child by bending down and feeling for the dorsalis pedis. For example, your high volume, wide pulse pressure, I'm sure the dorsalis pedis in this child will be bounding. It will give you a clue that there is wide pulse pressure,
Yes.
even without checking the BP.
Yes.
You can make a diagnosis of aortic regurgitation
Yes.
based on that alone. So that's the importance of such trivial physical findings in clinical medicine. Okay?
Yes.
Please go
Dr.
ahead.
SBS has rightly pointed out, when you feel the subcutaneous nodules, even if the carditis is not obvious, the child must be having at least indolent carditis or subclinical carditis. So that's an important clue too, not to miss carditis. Okay, right.
It could also be called as Pullman C-section. As we all can see, according to IMCA guidelines, we can see paler in the palpebral conjunctiva. There is a demarcation line present. Sir. I have visualized paler like this. Systemic examination. Neck, there is engorged veins seen.
1 minute, 1 minute, 1 minute, 1 minute.
Mhm.
In a child who has presented with arthritis,
Yes.
okay, which other examination is crucial? Exam question I'm asking.
Skeletal examination.
You call it skeletal examination? Anybody can put in the chat box what is crucial?
Musculoskeletal examination.
What do you call that? Have you all heard of P-GALS? Yes, Dr. Bharati is putting P-GALS. Your presentation is incomplete in any child who has got joint symptoms without examination of P-GALS.
Yes.
Okay?
Yes.
It's a must even in this child. You should ask 3 questions and go ahead to examine from head to foot all the joints, starting from putting the fingers, 3 fingers into the mouth and then going down right up to spine and legs. P-GALS is very, very crucial. It is one of the pediatric gait, arms, limb, spine assessment is one of the crucial methods of clinical examination required for anybody who presents with joint symptoms.
Yes.
Okay, please go ahead. Did you do that?
Yes, sir. There is no limb, sir. There is no gait abnormality, sir.
Okay.
There is no asymmetry also. Sir.
Okay, I assume. Probably the arthritis from your history has disappeared. Now the joints are normal. Am I right?
Yes.
Okay, fine.
Systemic examination, neck. There is engorged veins. Engorged veins are seen, sir. In neck, mostly prominently seen in external jugular vein congestion is seen, sir. As well as we can see there is internal jugular vein pulsations and raised JVP. Raised JVP is seen up till mandible, sir. Angle of mandible, the pulsations are being felt, sir. There are prominent carotid and carotid pulsations and prominent suprasternal pulsations, sir. We can see carotid pulsation here, sir.
What are the conditions in which you get suprasternal or carotid pulsations prominently?
Here, mostly in this case, it is of aortic regurgitation.
Very simple. The same hyperdynamic circulation
Hyperdynamic
causes
anemic
white pulse
conditions,
pressure will result all the condition
hyperthyroidism,
A, B, C, as I said, anemia,
anemia,
very,
thyrotoxicosis, beriberi.
thyrotoxicosis, okay,
Yes, yes.
okay, or PDA,
All hyperdynamic circulations.
all white pulse pressure,
Yes,
lesion, okay,
yes,
will
yes,
cause same carotid pulsation. And even aneurysm of aorta can cause carotid pulsation,
yes,
okay, like, or even suprasternal pulsations like that. Go ahead.
yes. Here we can see prominent carotid pulsations, sir.
Does she have a goiter, ma?
No, sir. It is looks like enlarged thyroid, sir, but she's in pubertal phase, sir, 10 years of age.
Okay, okay. And you should be careful in this child. You should palpate from the behind and
Yes.
ensure she doesn't have a goiter. Okay, fine.
I
Right.
have. Inspection, chest wall is elliptical and bilaterally symmetrical. There are no deformities. Apical impulse seen in left fifth and sixth intercostal space, 4.5 centimeters lateral to mid-clavicular line. Hyperdynamic precordium present, no precordial bulge. Trachea is in normal position.
Wait. I'm surprised that there is no precordial bulge. With so much of apical impulse being out and to the left, I don't know. I don't know. Such a big heart, there is very much likely to be a right heart enlargement also.
Yes.
I don't know. Do you have any picture of the chest?
I will show you.
Okay, fine. Or video. Yeah,
Yes.
there is precordial bulge. There is, you can see that
No,
asymmetry.
you can see in the. No, you can.
Yeah, you can make out the asymmetry of the chest. On the left, you see the left lower chest
Yes.
is more prominent than the right.
See in the
Yes.
image also, sir.
I will show it this, sir. This is more.
Hey, it is precordial bulge. Where is the doubt?
Yes. We could see apical impulse also, sir. In
Okay, there is precordial bulge. There is
you can see
parasternal here.
apical impulse in left fifth and sixth intercostal space, mostly shifted outwards.
Mhm.
We can see pulsations in second intercostal space also.
Mm.
Good shows more prominently.
I must appreciate you for taking the pictures and video and presenting. Very nice. Well done.
Thank you, sir. Yes. The trachea is in normal position. Raised jugular venous pulse 8.5 centimeters. Sir. Visible pulsations present in suprasternal region.
Which waves are prominent? A wave or B wave?
A wave.
Okay.
Again, show it. Show the video. Somebody may type in chat box also because it's so clear.
Prominent B wave. We can see prominent waves.
So what you see here is only prominent carotid pulsation.
Carotid
And what you
pulsation.
see on the left is the external jugular and not the internal jugular. I'm not able to appreciate the jugular venous pulsation in the video. Doesn't matter. I know it's very difficult. And another thing, what you have done, you have stretched the neck in such a way that vein won't be will not be veins will not be useful. You should relax and stretch
Yes,
it
yes.
backward. Otherwise, if she's keeping it flexed, you won't be able to appreciate the veins. It's okay, fine.
JVP is raised, sir. Right.
Okay.
Okay.
Here we can see the apical impulse shifted downwards and outwards in
Just a
4.5
minute. Just a minute.
centimeters lateral to mid-clavicular line.
Just a minute. Even in the video here, you see the left side of the chest is more prominent than the right side.
Yes.
Can you make out?
Yes. Yes.
Yeah, there is a parasternal. I'm sure there is a parasternal heave. In fact,
Yes,
Dr. Pramod has put in acute conditions, you may not get precardial bulge. I beg to differ. See, it takes hardly a week for the heart to hypertrophy and produce all this. And you never know whether this is the first attack of rheumatic fever, or she might have had earlier attacks also. We never know. I don't think it, I mean, physical finding is a physical finding. Explanations are different. There is definite parasternal heave.
Yes.
Okay. And
No,
precardial.
sir. You are talking about precardial bulge or parahepatic heave?
Sir, I am
Heave is
sure
there.
there must
Precardial bulge
be
we are
heave.
discussing.
The way it is,
Bulge.
the left side of the chest, I am sure there is parasternal heave also. The
No,
left
sir. Parasternal heave is there. But precardial bulge is not there. That's the
Sir,
thing.
parasternal heave is there means definite. Precardial bulge is there, sir, in the video. Whatever she is showing in the picture is very obvious. Yeah, even here you can make out the left side of the chest is more prominent. Okay, it's okay, fine.
Right, right.
It can occur even
So
acutely.
we are able to see the.
Here we can see the
Go ahead.
So it is diffuse and seen in fifth and sixth intercostal
Yes.
spaces. And okay, go ahead.
palpations. Inspectory findings are confirmed. Trachea is in normal position. Mitral area, apical impulse is felt in left sixth intercostal space, 4.5 centimeters lateral to mid-clavicular line, shifted downwards and outwards, diffuse and hyperdynamic capillaries. Systolic trill is present. Tricuspid area, systolic trill is present. In pulmonary area, there is palpable P2, sir. Parasternal heave present and axilla trill is present. Okay. Suprasternal pulsations present, carotid pulsations prominently felt, pulsations present over epigastrium, no pulsations over back, no palpable precardial rub, examination of back, no palpable sounds. Percussion, right heart border corresponds to right sternal margin and left heart border corresponds to apical impulse. Percussion over left second intercostal space is resonance here. Auscultation, mitral area, the first heart sound is soft, second heart sound is audible, S3 gallop presence. High-pitched, apical, soft-blowing, pansystolic murmur of grade 5/6, best heard with diaphragm of stethoscope in supine position and best heard in expiration. Murmur is radiating towards left axilla and inferior angle of left scapula. A soft diastolic murmur heard in early mid-diastole. No presystolic accentuation is seen. Aortic area, first heart sound barely heard, second heart sound is soft, early diastolic murmur, which is high-pitched, soft blowing, heard in early systoles. Decrescendo murmur of grade 4/6, best heard in sitting and leaning forward position and best heard in expiration with diaphragm of stet radiating towards apex. Tricuspid area, the first heart sound is normal, sir. Second heart sound is audible. Pansystolic murmur of grade 3/6 originating from mitral area is heard, sir. Pulmonic area, first heart sound is barely heard, sir. Pulmonic components of second heart sound is loud, sir. Herbs area, high-pitched, soft-blowing, early diastolic, decrescendo murmur, best heard with diaphragm of stet in sitting and leaning forward position at expirations.
What is Erb's area?
Left second intercostal.
I don't think that terminology is
Left
used in standard textbooks. It's no more used. It's a very old term. No more. You just specify where it is.
Left third intercostal space.
One. Again, the diastolic murmurs are usually not graded.
Yes.
Not graded. It is only the systolic murmurs which are
Okay, sir.
Graded.
Okay, sir. I'll
Traditionally, I'm saying traditionally, no recent textbooks in or clinical methods books grades diastolic murmur. That is my comment number 2. And avoid using the term Erbsbergia. Instead of that, you mention second intercostal space.
third
That's my
yes.
comment. And okay. So what you hear are a pansystolic murmur in the apex conducted to axilla,
Yes, sir.
and an early diastolic murmur in the
Aortic areas.
aortic area.
And a mid-diastolic murmur heard in mitral areas.
Okay, you have put first sound is normal. Is it normal? What
Sir,
about first
in
sound?
tricuspid area, the first heart sound is normal, sir. In mitral area, the first heart sound is
No.
Soft.
My fundamental doubt is you are hardly hearing the first heart sound in the mitral area, but how can you hear it normally in the tricuspid area? Is it possible?
I mean,
No, is it produced by different mechanisms in tricuspid area in mitral? You can't. I think first sound in this child, I expect to be decrease in intensity
I
everywhere.
mean, it is
I hope you
decreased,
see
sir,
the
relatively.
right
But
now.
compared
Sir, can I
to
come?
various,
Yes.
It's not likely. It's not likely. Everywhere, there is a first sound in this child would have been
decrease.
okay.
So,
Yes. Please speak up,
okay, I was.
ma'am.
I wanted to tell you, sir, actually previously it was not the classification, but recently there's a classification grading of systolic murmur 1 to 6 and grading of diastolic murmur 1 to 4 is there. That is the latest classification and grading of murmurs.
Okay. Because the recent clinical books don't mention grading of diastolic mode. Okay, fine. I
No,
stand.
it is from,
I stand
it is there
corrected.
in Nielsen in long time, long, 3-4 editions.
Okay.
Then we did them, it's still there. Diastolic up to 4 and systolic up to 6.
Okay. Okay, fine. Fair enough, ma'am. If there is a reference, fine. It's not no problem.
Okay, thank you, sir.
Hutchison doesn't grade murmurs,
Last,
diastolic murmur. That's standard. And Hutchison similarly does not talk about the percussion at all nowadays. So, I mean, these things are
In cardiology,
changing.
we don't do percussion, except in pericardial
No,
effusion.
see,
We do the
but
percussion.
ma'am,
Others,
ma'am,
no, it is not done.
Okay,
for exam's purpose, for completion sake, we will do it. Lest the examiner doesn't think that this fellow doesn't know that there is some heading. For exam purpose, for completion sake. Dr. Lasya, why the first heart sound is so soft?
In mitral regurgitation,
Why it is soft?
the jet is the jet of mitral regurgitation.
See, the first heart sound is because of the closure of the AV valves. In this
Yes.
case, mitral valve. When
Yes.
there is deformity,
Mitral-
distortion, or prolapse,
Okay, go ahead.
of a valve will not result in proper coaptive area. It is bound to be soft.
Coarctation of the
Okay,
valves is
then
not
as you have rightly done, we shall comment on a sound or murmur at its place of origin. So when you are talking in the mitral area and tricuspid area, you better not comment about the sounds which are not originating there. That means second sound you simply say that is audible. And the presence of S3 denotes. What does it denote? In this child, there is S3 you say. It is a mitral S3. Obviously, you have mentioned in only mitral area, not in tricuspid area. What does it mean? What does it indicate?
It's going into cardiac
No,
volume
in the
overload.
undergraduate in physiology we study, just a minute. Physiology we study, presence of third heart sound is normal, physiological in children. But when there is heart disease, it is an ominous sign. What does it indicate in this scenario?
It indicates firstly heart failure, sir, and in mitral regurgitation, the volume goes into left side.
Okay, there are two things. As Dr. Karan
Cause,
Dajaretti has mentioned, it is because of the most important. Why I am saying ominous is it indicates acute left ventricular failure.
Yes.
One. Number 2, because of regurgitation, the backflow, again, more volume of blood enters the left ventricle. That also may produce S3. So when do you call gallop? S3 is there. When do you call
Tachycardia
gallop?
also
When it is
present.
associated with?
Tachycardia.
Associated with?
Tachycardias.
Tachycardia. Again, gallop is a red herring finding. And so you can very well say this is organic murmur because it's grade 5 and it is high pitch. And why it is heard in the axilla better?
It's
What is
the
the reason?
jet
What
is
is the predilection
radiating
to
towards
axilla?
the jet of the mitral regurgitation is
It's all related
radiating
to
to
jet of the blood, how it traverses. So unlike in
yes.
textbooks of the high school children, the AT are not on higher side and ventricles are not lower side. Okay, it follows the jet of the blood that is being ejected out. Right. And what is the explanation for hearing the early diastolic murmur and a diastolic murmur in the mid diastole also? What are all the causes? Because you have complete auscultation.
Yes.
Okay, first you talk about the
could-
murmur in the mid diastole.
It could be a Austin Flint murmur, sir, because
But
the
before Austin Flint, you confine to first of all mitral area. You are right, but you tell first point which is confined to related to mitral area.
yes.
You yourself told that
Yes.
there is regurgitation of blood into left atrium. When
It's
the normal quantity
volume
of blood
overloading,
passes through the stenosed
more
valve
volume of
or
blood
large
through
amount of blood passes through,
normal functional
uh,
wall
it
causes
may
turbulence,
result in again
and it causes
mid-diastolic
murmur.
murmur.
Yes.
Then how do you differentiate from mitral stenosis? MS and MR can be coexisting. Why can, by what point you can say that it is not mitral
There is
stenotic
no
murmur?
presystolic accentuation presence.
One thing is that is a harsh rumbling.
Harsh
This is not
rumbling.
harsh
It is
one,
a
not
soft,
rumbling, and there is no
soft
presystolic
diastole.
accentuation.
Yes. Yes.
Okay, and what's the cause for early diastolic murmur?
Aortic regurgitation. I mean,
See, aortic, how it radiates, aortic regurgitation murmur.
it radiates towards the anterior leaflet of mitral
Okay, that
valves.
impinges on the anterior leaflet. Okay, it
Yes.
radiates from the aortic area, that is second aortic area, third left ventricular space, and then to apical region.
Yes.
Okay, so that is the area how it radiates. So when the regurgitated blood impinges on the mitral valve leaflet, especially anterior leaflet, because of the flutter, there can be diastolic murmur in the mid diastole.
Yes.
That is because of the regurgitant blood causing flutter in the mitral valves. In the early diastole, there is same one that is being radiated. So, aortic regurgitation, in the aortic regurgitation, there can be murmur in the early diastole and mid diastole also.
Yes.
So, what is that murmur called? Aortic regurgitation.
Austin
Yes, you
Flint
told previously.
Austin Flint murmurs.
Right. So, you have to rule out mitral stenosis. Is there any possibility of this child having mitral stenosis?
No.
Because of the first of all age. Western textbook says the rheumatic heart disease is very unusual or not seen in first decade.
Yes.
But unfortunately, this girl is having rheumatic heart disease, liver and carditis. Secondly, the stenosis doesn't appear as early as regurgitation. Okay, it's mitral regurgitation, aortic regurgitation, a little later, or some years mitral stenosis. Okay, but anyway, based on the physical findings, you have to tell. Just because first heart sound is dull, soft, because of don't think of mitral stenosis in which the valves were calcified. Okay, next.
Actually,
Suppose you next.
Dr. Lyas, Dr. Ramakrishna
Go
sir,
back. Yes, sir. Yes, sir. Go back.
if you go through the history of rheumatic fever and rheumatic heart disease in India, there were actually two pioneers, both are no more. One is Dr. Padmavati Menon from New Delhi, sir. You must have known her, pediatric cardiologist. She described juvenile mitral stenosis in India, right? Like you said, in the West, mitral stenosis takes 2 years or 3 years to develop. But in pediatrics, Dr. Padmavati Menon has developed, described and
Reported.
published juvenile mitral stenosis, and she attributed the malnutrition in these children, making them responsible to get tight mitral stenosis even within the first 3 to 6 months after rheumatic fever. So, calcific mitral stenosis with tight mitral stenosis, she has reported within 3 to 6 months. Similar reports have been done, have been published from Chennai by Dr. Solomon Victor, again another cardiac surgeon, who has shown with publication that mitral stenosis in India can occur much faster than in other countries. Maybe we are
Yes,
seeing
sir.
less and less cases in India these days. They may behave like the Western rheumatic fever with mitral regurgitation, but mitral stenosis can occur as fast as 3 months. There are enough case reports from India and from developing countries. So it is not
Yes, even
necessarily.
Ghai also mentioned that.
Yeah.
Ghai statistics also
Juvenile
mentioned
mitral stenosis.
that
Yes,
because of the increased streptococcal infections,
Correct.
more chances of repeated
Correct,
streptococcal
correct.
infections, MS gets
Yeah.
early age in India.
It is described very much in literature thanks to these two pioneers of cardiac. Hello? Okay, please go ahead, Dr.
Yes.
Lyashasvi.
Yes. Following our peripheral signs are elicited, observed, sir. Corrigan's pulse present, sir, and collapsing pulse or water hammer pulse present, sir. Trobis sign present, sir. Landolfil signs present, sir, and Hill signs present. I will show you Landolfil signs, sir. Here it can be elicited beautifully, sir. Systolic contraction and diastolic dilatation present, sir. We can observe here as contraction and dilatation. You can see here, sir, contraction and dilatation.
No, don't, people will observe. Don't put the
Yes.
cursor.
Yes.
Okay.
Yes. Shall I go to next slide?
Next slide.
1 minute. It is simply fantastic. In fact, Dr. Ramakrishna, I would suggest you send this to BMJ student and you will definitely get this publication. Please send it tomorrow. They'll definitely
Thank you,
accept
sir.
it. They'll definitely accept it. Take the permission of the patient,
Thank
send the video. Definitely, this will get published in BMJ student without any rejection. Wonderful. I have not seen. Fantastic. In fact, this
Yes,
is
sir. Very
Yes, sir.
nicely documented.
superb. Superb. You can ask one of the same student to prepare and send. Okay.
Okay, sir.
Yes.
Brilliant.
Yes.
The first time I have not seen this before. Fantastic. Honestly, I wouldn't even have looked for this.
Examination of musculoskeletal system. Examination of right ankle joint normal. Examination of right wrist joint normal, sir. All other joints are normal, sir. There are no kyphosis or scoliosis. Other system. Respiratory system. Normal vascular breath sounds heard. No adventitious sounds. GIT. Abdomen.
Lasya,
Yes.
Lasya, just
Yes,
wait for a minute. Lasya,
Yes, sir.
just a minute. Where else you can ask? You will auscultate just for completion as a student.
Sir.
Where else you would like to auscultate? You auscultate over the back of the chest.
Chest, sir.
Auscultation or inspection and palpation are not complete without examining the back. One.
Yes.
In this case, you may hear a pansystolic murmur. You may
Yes.
put your stethoscope over the large
Left.
superficial vein like
or-
extrajugular vein. You may
Yes.
hear a venous hum,
Venous
right?
hearts.
Just for the
Yes.
completion.
Yes.
Even though they may not add to the diagnosis, but have you mentioned about parasternal heave? Sir, I did
Yes,
not
sir.
mentor
I
her
have mentioned
completely
about
because not
parasternal
that I am
heaves.
perfect. If I do it totally, there will not be much discussion left. That's why I allowed her to do some preparation as she likes it, right? You have to examine the posterior chest also, right? In all cases. In this
I
case,
have
it is, you can hear
examined
that.
the posterior chest, sir. There are no palpable pulsations or any pulsations seen, sir. And I have also auscultated, sir. I have heard pansystolic murmurs in left.
Go back once. Okay. Go back once. Go back. Go. Suppose I hear a systolic murmur in aortic area. What's your take? I had a systolic murmur, ejection systolic murmur, crescendo, decrescendo murmur in aortic area.
Aortic stenosis, it could be a case of aortic stenosis, crescendo, decrescendo,
See,
ejection
this
systolic.
girl at the age of 9, 10 years is
It
having
cannot
so
be.
many problems. Don't
Yes.
add aortic stenosis to that girl.
Yes.
Okay? She is practically very unfortunate to have all these things. Again, I was telling you, through the normal wall, increased flow of blood, or through a stenotic wall, normal flow of blood.
Normal flow
So
of
when
blood.
there is aortic regurgitation, lot of blood is going
Yes,
into the
yes.
aorta. Again, it is
Volume overload
leaking back
on
into the ventricle.
normal
Again,
walls.
so it's a large output state. So
Yes.
what is happening? Across the aortic wall,
No,
more
across
blood
the
is passing.
normal wall, more blood is passing. Functional murmur hurts.
So it may result in functional ejection
Murmurs.
systolic murmur.
Ejection
How to
systolic.
differentiate? Somebody may have doubt it is aortic stenosis is part of rheumatic fever, which is not. Then how to somebody ask you, how to say it is not organic?
No click. Ejection systolic click
Good.
is
Ejection click will not be there. And
Yes.
secondly, it will not be harsh, and
Harsh.
the grade will be lower. Okay.
Yes.
Right. Next.
The two things, the
See,
presence of
you said pulmonary
overwhelming signs,
hypertension.
the presence of overwhelming signs of an aortic leak with so many peripheral signs. I mean, straight away rules out stenosis. You cannot have stenosis when there is so much of wide pulse pressure with large volume and all the
White
peripheral
pulse pressure
signs.
and all.
So you can simply cannot have stenosis in this style.
Yes.
Possible.
Right. That's self, right. And seeing the pulse also, you can tell.
Yes.
That's
Yes.
great. See, you said pulmonary component of the second sound is loud. What's the
Yes.
explanation?
Could be due to pulmonary hypertension, congestion of pulmonary
Which
veins.
ventricle is affected first? Left ventricle?
Left,
Left atrium? Which chamber? Left ventricle? Left atrium?
atrial,
Right ventricle?
mitral.
Right atrium. You tell me the order. No, don't get tense. It's only to face a tough examiner in your final exam.
Mitral regurgitation, LA volume overload presence, sir. The pressure is carried to pulmonary vasculature and there is pulmonary
It is the
congestion.
left ventricle that is bearing the brunt because it has to pump large volumes of blood. What is
Yes.
its quota? Plus the regurgitated blood from the left atrium, plus regurgitated blood from the aorta. So in three ways, left ventricle is burdened, overburdened. Is it volume overload or pressure overload?
Volume overload.
Volume overload. It is getting blood in three ways. So it's volume overload. What type of failure it is called? Systolic failure or diastolic failure? Of the left ventricle. Anybody may see everything you are leaving to see what is happening to the chat box. People suddenly got silent. Is it systolic or diastolic failure? That also we are supposed to know.
Left ventricle volume
Somebody
overload causes
mentioned the
dilatational
chat box.
dilated cardiomyopathy.
No, I am not asking that
chamber
one. Is it
dilatation.
systolic or diastolic? What type of failure you call it? Yes, Nandini, you are right.
System.
Right. Then comes why the right heart is failing. See, primarily it is the left ventricle that has to do a lot of work. Left atrium, back pressure. Then how come the right ventricle can get to fail? So all these things are going in a very quick succession. There may be some report somewhere, but in the exams you don't mention those things. And why there is right ventricular or right heart failure, as evidenced by pedal edema, puffiness of face, and the other one you may tell afterwards whether there is hepatomegaly or not. Then why should the right ventricle fail? And what does it indicate? We'll give 2 minutes for the chat box and then we'll discuss it again. Right. Next. And you put your stethoscope over the carotids also. You may hear. You may hear.
Bruit.
T is silent. T is silent. Carotid bruit.
Bruit.
It's only just as a student, some people are fond of asking various questions that may be present. Okay, to that extent only, not to get the diagnosis. See, exams are exams. You have to prepare for the exams, unlike a consultant. Next. Next. Sir, Dr. SBS, please see the pulsations in the abdomen also. That is also not usual.
Okay,
Yes, you go to.
one finding which is not probably complete. There's no point
it's
talking about enlargement of liver below right costal margin without mentioning the liver span. Liver span. And you just show the abdomen once more.
Right.
The abdomen picture. Show me. Yeah. If you see here, let me tell you, it looks like the umbilicus is pushed down. You see here, the umbilicus is pushed down and stretched down. I'm afraid this child's hepatomegaly is significant. I'm sure. You see here, the upper abdomen is more prominent than the lower abdomen. The umbilicus is stretched down. And, the upper abdomen is full. I think the liver span should be mentioned. I am sure this child has got hepatomegaly, which is significant.
Yes, sir. See, what I'm asking you to observe is, you are seeing the pulsation so clearly. Epigastric, umbilical, and hypogastric region also. Very classical. She is not very thin, but still we are observing the pulsations in the hypogastric area. Right. I don't think so any textbook mentions it. So much of prominent pulsations in the extending down to hypogastric area. Lastly, what could be the cause for so many prominent pulsations?
Abdominal aorta thrust.
See,
So much of stroke
it is
volume.
large volume of pulse that is going into the aorta. Right.
Yes.
Stroke volume is
Hyperdynamic circulation.
stroke volume is very large. Okay.
Yes.
Again, it's also a little unusual finding to see the pulsation so clearly down to hypogastric area.
Dr. Pramod has correctly put 3 centimeter below right costal margin is not hepatomegaly. Hepatomegaly is diagnosed based on the liver span. You should percuss then only mention. But I am sure this child has got hepatomegaly. Even without touching or percussing, I can tell you. Because everything is pushed down. You can make out. Okay, leave it. It's okay. Don't forget to percuss the liver and tell about the liver span. Don't talk about hepatomegaly based on palpability. It's based on liver span.
Right.
Go to the next.
But what probably, of course, that's a good habit, but there is no, Dr. Pramod Kulkarni, there is nothing in the chest that pushes it down. No, we are expected to do the span, but in the absence, there is nothing much to push down in the chest, pushing the liver down. Okay.
No, you can't say that because this child has cardiac failure.
We have to.
This child has got cardiac failure and is
Yes,
having respiratory distress. The diaphragm may well be pushed on because of pleural effusion.
After examining the respiratory system, I am telling.
Yeah.
Right. Next.
Fundamental point that you must all postgraduates remember.
No, we shall.
Mention liver span to justify hepatomegaly. That's all. That's a very valid point raised by Pramod. Yeah. Go ahead, ma.
Yes. Clinical diagnosis. It's a case of acute rheumatic fever. 2 major criteria and 1 minor criteria met. 2 major criteria met are carditis and fleeting type of polyarthritis. Minor criteria met are fever. Rheumatic, it is also associated rheumatic heart disease with mitral regurgitation and aortic regurgitation. And heart failure present, sir. Congestive heart failure and left heart failure present. No infective endocarditis. And associated with nutritional anemia. Mostly iron deficiency anemias.
Okay, I think so. It's the diagnosis is straightforward. My only question to you is,
Yes. Yes, sir.
why not the whole thing may be only rheumatic carditis without established heart disease? I'm just asking I'm devil's advocate. I'm a devil's advocate. I'm questioning you. I'm saying I don't disagree. I don't agree with you that this is rheumatic heart disease. I'm saying the whole thing is carditis. And again, one second comment is, if you say carditis, you should always classify whether it is mild or severe. That's very important. Do you think
Yes.
this carditis in this child is mild or severe?
Severe, I mean,
Severe. She has got cardiac failure, such a big heart, so much of symptoms, tachypnea. Straight away, you should say carditis, which is severe.
yes.
And I mean, suppose I'm asking you, why not this be only carditis without rheumatic heart disease? But the whole history is only 10 days. How do you defend yourself?
Just a minute.
With so many
Sir,
peripheral signs of
2 minutes
aortic
to the people
regurgitation.
to type in the chat box. Why it is carditis? Why not it is carditis alone? Why it is not simply rheumatic heart disease? Why can it be both carditis as well as RHD? Please type in the chat box before Dr. Bala clarifies it. Wait for some time. Anybody would like to tell why it is not simply carditis? Because the child is having rheumatic fever. Why should we think of rheumatic heart disease also? No one. Yes, sir.
Very simple answer. The
With
whole
so many peripheral signs of
so short. It is only a 10 days history.
Yes.
Within 10 days, you can't have so many physical signs unless there is a pre-existing valvular heart disease. Like I said earlier, this child who's got such a big heart, so much of symptoms, severe cardiac failure. I don't think the whole issue has started 10 days back.
Current 10 days.
Must have been an underlying disease, and you don't have the history. Of course, the history is because she's in a hostel. You can always defend yourself. Okay. And you can say this must be a pre-existing rheumatic valvular disease. It has been worsened by this acute attack of rheumatic fever. That is one. Second, any child who has got an established rheumatic valvular disease, if the child deteriorates, you should always think of only two things. Possibly you have three possibilities. One, an acute carditis or an acute rheumatic fever. Second, if there is a pre-existing valvular disease, a superadded infective endocarditis. Third, rare, natural course of worsening of the valvular disease. Last, fourth, comorbidity like anemia. These are the four possibilities.
Yes.
If you have a child who appears to have a rheumatic heart disease, who deteriorates. But having said that, unless proven otherwise, any child with rheumatic valvular disease who deteriorates must be assumed to have or must be diagnosed to have carditis unless proven otherwise. I hope you get the message.
Yes.
That's it. Then my next question is, you have said that there is a fleeting type of polyarthritis.
Yes.
Okay, with carditis and all. Is there any other differential diagnosis other than rheumatic fever for this girl? Again, I'm asking.
Systemic juvenile idiopathic arthritis.
Hey, come on,
See,
will you diagnose systemic in a child who has got MS, MR, who has got
I mean, no, sir.
You cannot
For
have so many
fleeting type
things,
of
right?
polyarthritis only,
No,
I'm telling.
don't say
no.
unnecessary
Not with
reading. Don't
carditis
entertain
and other
unnecessary.
things.
Dr.
Sorry, sir. I
Lasyasvi,
have misunderstood it, sir.
the only diagnosis I will not think of in this child is OJAA.
I thought of fleeting type of polyarthritis.
My question is, what other differential diagnosis will you think of in an adolescent girl who develops cardiac failure like this with multiple valvular lesions? Is there any other disease will you think of?
Infective endocarditis.
Excellent. Yes, you should think of. There are any number of reports of native wall infective endocarditis, however uncommon they may be.
Yes, sir.
And in fact, I have seen one or two cases of infected endocarditis, native wall endocarditis, presenting like this.
Without any heart disease. Without any heart disease.
Very rare, very rare.
Right.
Yeah, native wall. Nothing may be there. There may not be dental extraction. There may not be any underlying valvular disease. Okay.
Last year we saw a case, sir.
Third,
Last
yeah.
year we saw a
Third,
case. Dr. Bhargavi, you are right. Right.
agreed. Third condition that you would think of, you should think of in this child is a primary myocardial disease other than rheumatic myocarditis.
Yes.
Like, for example, dilated cardiomyopathy.
Yes.
And you must remember, dilated cardiomyopathy is a syndromic diagnosis.
Yes.
It can be multifactorial, starting from thiamine deficiency to Coxsackie virus infection to genetic causes. Okay, to
Yes.
drug toxicity.
Yes.
It's a syndrome. So dilated cardiomyopathy is one other differential diagnosis. Of course, the other diagnosis you should think of in an adolescent girl who develops myocardial dysfunction and cardiac failure is SLE.
Yes.
SLE can cause transient arthritis.
Transient
It did
arthritis
not
and
cause erosive arthritis like SOJ-A.
Jacob's
Right?
atrophy.
SLE can fool us. In this girl, adolescent girl, yes, SLE is one differential diagnosis. The only point against SLE is that you don't develop such severe valvular lesions. You get more of myocardial lesions or pericardial effusion and myocarditis and failure and rhythm abnormalities rather than this sort of high output cardiac failure with aortic regurgitation, etc. The next diagnosis one has to think of other than primary myocarditis, very rare. If you ask me whether I have seen, I would say I've seen only one Kawasaki disease. Of course, you don't get arthritis like this. And this is an unusual age. 11 years is not the age. Below 5 years, most cases of Kawasaki are below 5 years. You can very well have severe myocardial dysfunction, but not aortic regurgitation. It's more of a myocarditis and shock and cardiac failure, etc. It's very, very unusual. And rarely, we have to keep in mind severe iron deficiency anemia can fool all of us. Adolescent girl, they can come to you with 3 grams hemoglobin with cardiac failure, with comorbid infection, respiratory infections and things like that. That is very, very rare and unusual. And of course, few rare things that you should think of is myocarditis occurring as part of fulminant chronic infections, including HIV infection causing myocarditis and myocardial failure, very rare, etc. Okay, these are the thoughts I would that would come to my mind at this point of time. Last is, of course, a pericardial effusion causing tamponade, something like constrictive pericarditis, which can be notoriously caused by something like tuberculosis, which can cause, but you don't get this sort of murmurs, and you get more of right ventricular failure with edema rather than this sort of murmurs and things like that. Child will be much more sick than this. These are the thoughts at this point of time. Over to Dr. Ramakrishna at this time.
Yes,
Before
we'll
we
proceed.
look at the investigations.
Right.
Yeah.
Proceed,
What will
proceed.
you do for this
Last.
child? And what will you do for this child? If you are the resident on duty of this child, how will you investigate this child? What investigations did you do? Please go ahead.
I would do initially chest X-ray and 2D echo, sir. First of
Can
all, I
you
would
have the chest X-ray of this patient? You have the chest X-ray of this patient?
Yes, sir, I have had.
Please show me. Yeah, just go through
Could
the.
I tell investigations also, sir? HB, she has anemia and HB of 8.1 grams per DL with CRP of 115 milligrams per liter and ESR is 110 mm in first hour, sir, with ASO titers of 800 international units per liter, sir. I have done ECG, sir. I would interpret the ECG, sir, with your permission. We can see there is a normal sinus rhythm, sir, with each P wave followed by a normal QRS complex. And we can see in every way, we can see the PR interval is prolonged, sir. It is 0.2, sir. In children from 3 to 12 years, more than 0.16 is considered prolonged, sir. We can also see in V5 and V6, there are tall R wave, sir. We could correlate with the left ventricular volume overload, sir. It could be due to volume overload due to aortic regurgitation or mitral regurgitations.
Okay, go ahead.
Yes.
What do you expect for P waves? What will happen to P waves? P wave.
Right ventricular
What do you expect?
enlargement present, it could be P mitral present, sir. And in MR,
No,
it could,
P wave.
sir.
Lascia.
Yes, sir.
P wave. What will happen to P wave in ECG?
I mean,
So P
left
wave will be
ventricular
prolonged. It can be
enlargement,
called P mitral.
sir, that only happens.
Left atrial enlargement. Prolonged
Left
P wave.
P
Duration
mitral.
is prolonged. They can be mitral.
Notched P waves and
So-called
P
P
mitral
mitral.
could be
Okay.
present, sir. I mean, in left atrial enlargement, notched P waves and ventricular enlargement, it could be of left P mitral could be present. Modified Jones
Right.
criteria, the major criteria
Do you find any arrhythmias?
No, no
Lascia.
arrhythmias.
Do
No
you find any
arrhythmias.
arrhythmias? No, this girl
In
doesn't
left
have.
ventricular,
Do you look for any
in left
arrhythmias?
ventricular enlargement present
No,
due to
in this
mitral
case,
regurgitation. No, sir. In this case, there are no arrhythmias. Till
no,
present,
see,
no
what do you expect
arrhythmias.
in such scenario? What arrhythmias?
Supra
You may have
uh,
atrial or ventricular arrhythmias.
yes,
Frequently is atrial flutter when there is so much
flutter
of
could be present.
enlargement. Okay.
Yes.
Next.
Go ahead, please
proceed.
go ahead. Go to the X-ray.
Yes. Yes.
Please show me the X-ray. Yeah.
This is chest X-ray, sir. I mean, it was not so good X-ray film, sir. This is chest X-ray PA view. In mid expiration, it has taken, sir. We can see there is increased cardiothoracic ratio, sir. And there can be seen increased vascular markings and pulmonary base obliterated, sir. We can see the right heart border enlarged, sir, as well as left heart border enlarged, and the right heart border enlargement corresponds to right ventricular and right atrial
Right heart border
enlargement.
corresponds to right
Ventricular and atrial enlargements.
atrial. Right border is right atrial.
Atrial enlargements, sir. And left heart border is also enlarged, sir. We can see is minimum, it is mostly outwards, sir. It could be left ventricular and right ventricular enlargements. It is in this X-ray, I could, if at all abdominal aorta is visible, I could comment on that, sir. As there are more abdominal pulsations we have seen in epigastrium. It could be dilated, sir, if at all present. I have
In a
taken
good
another
field,
X-ray
you would
also.
have noticed aortic dilatation. In a good field, you could have
Yes.
identified or observed aortic dilatation also. Dr. Bala, your
Yes.
comment on the X-ray. And you are seeing the non-radio opaque shadows in the
sorry.
mid-zone.
This is an X-ray which is AP view, which is taken in the probably as a bed film.
Yes.
Massive cardiomegaly with a cardiothoracic index of approximately 0.6.
More than point.
And the marked increase in pulmonary vascular markings, both sides indicating pulmonary edema.
Yes,
And
sir.
other than that, I can't make out any pleural effusion very obviously in this. This is probably
Yes,
a bed
sir.
film taken AP view in the recumbent posture. I don't, I mean, child must have been sick at that point of
Yes,
time.
yes.
Anything more than cardiomegaly and probable pulmonary edema, I can't make out.
Yes, sir.
These are my findings in this X-ray. I won't, I mean, this is, with this, I would only say there is massive biventricular hypertrophy with
Enlargement.
rounded apex and pulmonary edema. That's what I would comment on. there is no typical straight border of mitralization of the heart like you see in mitral stenosis. That's all I can say. This can occur in any cardiac failure with primary myocardial disease also.
Yes.
It doesn't give a clue that it is rheumatic.
Yes.
You can have this typical straightening of the left border, etc., which can occur in mitral stenosis. This is not mitral stenosis. This is myocardial failure. That's what it looks like in this X-ray. Please move forward. Yeah.
Yes.
Go ahead.
I have
What about
taken
Can
another
we see
film
left
also,
atrium?
sir.
Last week.
Yes.
Can we see the left atrium
Yes.
enlargement in the PA view?
I didn't see, sir. It is
You
massive.
see, in PA view,
enlargement.
we may not appreciate the left atrial enlargement because it forms the posterior, and you may see
Posterior,
the left auricle forming
left
the left border of the
auricle.
heart. In our PG days, people used to use the see the indentation or the esophagus because of the left atrial enlargement that is not required with nowadays, and auricle enlargement may be seen, and lateral view, don't take it, you can identify, but it is exposing more radiation to the child. It's not required because other signs are obvious. You say that
Yes.
enlargement of the left ventricle is there, left atrial enlargement is there, right ventricle enlargement is there, right atrial. All four chambers are enlarged. Okay? Right. Next.
This also in another film of X-ray, sir. In this also we cannot appreciate more, sir. There is increased cardiotoxicity.
The only difference between that film and this film is that probably this child might have received diuretics and the pulmonary edema is clearing.
Yes.
That's come down.
That's all I can make out.
Right.
The cardiomegaly is also slightly better when compared to the previous film, more so because, you know, and another thing is this is too well penetrated. It looks as if it's an X-ray of the spine. Okay?
Yes, sir.
Very high penetration has been there for this. Right, fine. Go ahead.
So I would comment on
Show the
two.
echo film.
Yes,
Next,
sir. I
next
have
slide
taken
first.
echo film, sir. With your permission, I would show the echo film, sir.
I don't think I can interpret all this much. Let me be very honest. Sir, Dr. Ramakrishna, probably you may interpret all this. I don't think I will interpret these echo finding. I'm ignorant. I'm honest in admitting. Anybody can.
We will see. We will hear what she's going to tell. Right. You start. Go from the beginning.
Yes, sir.
Right.
I have taken this and parasternal long axis view, sir. Parasternal view. Here we can see like left atrium, left ventricle, and this is aorta, sir. This opening is. Further goes, we can see there is a jet of aortic regurgitation as well as mitral regurgitation jet can be seen, sir. Here we can see aortic regurgitation jets.
Whatever you say is right, ma. Thank you.
No,
Yes,
sir.
yes.
Sorry for exhibiting my ignorance.
We can see here mitral regurgitation jets. This jet goes like this. We can see here. I will show the aortic short axis view, sir. You can appreciate
No,
more.
don't worry. I don't think it is required. Don't worry. This is not our area. I don't think
Go
you need
back.
to know also. Please leave it. No, we
Go
need
back. Go back.
more clinical
Okay,
things.
okay, sir. Okay, sir.
Go back.
I'm not saying this because I don't know. We should not expect even a student to know all these echo findings. It's not necessary. It's beyond.
This will go to the report.
Mitral and aortic walls are thickened, severe MR, anterior mitral deflate prolapse, severe aortic regurgitation present, trivial tricuspid regurgitation, mild pulmonary artery hypertension, normal resting left and right ventricular function, mild pericardial effusion, anterior to right ventricle it is 0.7 centimeters, sir, and posterior to left ventricle it is 0.9 centimeters, sir. There are no clots.
Why they comment on clots? Why did they
Uh,
comment on clots?
like in
Anybody? Somebody posted in the somebody posted in the
inflammatory.
chat box. Why they are commented on clots?
Yes.
See, whenever there is left atrial enlargement, there can be
fibrillary clots.
yes, atrium may go into
Fibrillation.
fibrillation of flutter. That means there is no effective contraction that results in some cases that may result in clot formation.
Yes.
And why we are worried is they may dislodge and cause embolism. Okay? Right. And there can be vegetations over the Damage wall
Valves. Yes.
because of the rheumatic heart disease. There can be vegetations because of the complications of the rheumatic heart disease. What is it? Which
Infective
complication may result in vegetations?
Sir.
Infective endocarditis.
Ah,
Okay. In all these three ways, there is a possibility of some embolism. Okay. Right.
yes. These
Good,
are
Dr.
other
Nandini, you are right.
These are other investigations, sir. Serum electrolytes, these are all normal, sir. Coming to treatment.
Okay, before
we
going to treatment, 3 slides before, quickly. Before, go to the previous slides, previous. Where? No, next. This is the one. See, acute rheumatic fever is essentially a clinical diagnosis. This is the criteria which met the diagnosis. Of course, there are too many criteria to confirm it is rheumatic fever, either 2 major or 1 major and 2 minor. Is there any third category which says that there is rheumatic fever? 2 major we know, 1 major, 2 minor we know. Can there be any other category which tells confirmatory that is acute rheumatic fever?
In recurrent
3 minor.
rheumatic fever, 3 minor
3 minor
criteria
also
could
can be taken, especially when it is
Yes.
recurrence. Right.
Yes.
In case of indolent carditis, even a single criteria is considered confirmatory. Right.
Yes.
So there are 2 major and 4 minor criteria. Okay. It's a classical case in a very young girl. That's why we have taken up with all textbook description of presentation of signs. So we are able to elicit so many signs. It's textbook like. So I thought it will be useful for the postgraduates being discussed by Dr. SPS. Yes, go back. Go to the next slides quickly.
Shall I go to
Next,
next slide? Yes.
Next slide. So why we have taken the electrolytes is not for confirmation, it's not for diagnostic value, it is to monitor because we are using fusimate and also digoxin. So when we are using these two, we are supposed to monitor the potassium levels because fusimate may cause hypokalemia and the hyperkalemia digoxin toxicity will be, digitalis tax will be increased. Yes, quickly, just mention and go through. Doses are not required.
Yes. Initially, we have given the benzathine penicillin of 1.2 million international units, sir, IM start dose, followed by tablet prednisolone 2 mg per kg per day per oral for 15 days it was given, sir. Later, it was tapered to 1.5 mg per kg per day, sir, for over 5 days, followed by which tapering was done, sir. And digoxin of 0.125 mg per dose was given for over 20 days, sir. And she's on enalapril and furosemide, carvedilol, and pantoprazole. These are the treatment given during hospital stays.
Okay, I have two comments. I have 2 comments on this. One, digitalis, we are not using it all. We have not used digitalis for such cases, number 1.
Yes.
Number 2, this child who has got such severe carditis,
Yes.
I would have given pulse methyl prednisolone instead of prednisolone.
Yes.
I would have hit hard in the beginning for the rheumatic carditis.
Yes.
Right? And
Yes.
the rest of the things, perhaps, okay, enalapril and furosemide combination is very good because when you combine this, the risk of hypokalemia comes down because enalapril retains your potassium, furosemide decreases potassium. It's a good competitive antagonism. Carvedilol for supporting of the myocardial function. And digoxin, we don't use it all now. We have not used digoxin in such cases in the recent last 10 years, I would say. Rest is all okay. And in this patient who doesn't have infection, I would have straight away started iron also. Iron. Because I would have looked at the hemoglobin, red cell indices.
Yes, sir.
And if I'm sure there's no splenomegaly and I'm not thinking of hemolysis, etc., I would have added iron to this girl very much. And that's what I would have done. and I would have called the parents and I would have counseled them regarding the nature of the diagnosis of this girl and thing. And in the treatment part, this girl, I don't think this girl can go to school. Because with
No,
such
sir, we have
cardiac
given
failure-
complete bed rest for her 6 weeks.
that should be added. Bed rest. I think this child at
Yes.
least requires hospitalization and bed rest initially for thing, and I don't think you can send her to school right now. Should have added that
Yes.
in the treatment measures.
Yes. I would-
Counseling about the rheumatic fever, and also in the presentation you should have mentioned the teeth also. Very important.
No, dental care is mentioned, sir.
Dental cardiac
It was
hygiene.
present, sir. We have
Again, treatment
Yes.
measures, you should have mentioned counseling on dental hygiene. Dental
Yes.
hygiene. Even if the teeth are normal, I would refer this girl to a dental surgeon right in the beginning to ensure that everything is fine, to prevent future infective endocarditis. And the family should be counseled that this girl would require penicillin prophylaxis lifelong.
Yes, sir. Lifelong. Yes.
That's it. What is the weight of this child you put? What is the weight?
31.
Huh?
31 kgs.
Okay.
31.
Below 28 kgs, it's 0.6 million and
0.6 million
above
international.
0.2. And in this girl, I would not consider any prophylaxis other than benzathine penicillin. In fact, interestingly, there are now research activities going on to find out whether you can give benzathine penicillin long-acting subcutaneously. I believe there are new preparations which are undergoing trial where you can give it once in 15 days. If you give higher doses once in about 50 days. That's one, it's coming up. Trials are going on. We may soon have longer acting benzathine penicillin in a different form subcutaneously with less pain. That is one. Second is all other methods of prophylaxis, including oral penicillin, are inferior. You should not be giving for this patient. And India, mind you, oral penicillin that is available in India is not penicillin V. It's only the stupid penicillin G. Sorry to use strong words. Penicillin G, Pentich, is poorly absorbed. It has very poor bioavailability. You shouldn't be using it. The other alternatives, azithromycin or amoxicillin, which are much less inferior, we should not be using it. This girl would require probably lifelong. And of course, this girl has also got to be followed up. This girl who has got such a severe mitral regurgitation, aortic regurgitation, may have to be followed up for exploring surgical options early. But the disease looks like it has already hurt the child very badly. And I would say that the whole history is only 10 days. This is not the first time this girl is having the problem. I am sure this must have been one of the multiple attacks she must have had. She must have had earlier pre-existing rheumatic valvular disease, which has become decompensated due to the
Naturally, sir. That's why the baby landed in rheumatic heart disease.
rheumatic heart disease.
That's
That's one.
this is
And,
see,
yeah, more importantly, it's very, very important for the primary general pediatrician to recognize rheumatic fever and rheumatic carditis. There are some difficulties in the diagnosis of rheumatic fever, which includes, wrong interpretation of simple test like ASO. Every ASO titer elevation is not rheumatic fever. That is one. Second important point, we Indians must remember, India is becoming a low endemic country rather than high endemic country for rheumatic fever. I was surprised to read same Lancet article. India, there's a map. India is not anymore a high endemicity country. So you need not consider arthralgia as a sign for rheumatic fever in India. Okay.
Sir, in this case, won't you consider the aspirin after tapering a penicillin 2 to 3 weeks after that?
Pardon?
Because there is a heart failure is there, so corticosteroid is started, prednisolone. And after 2 to 3 weeks, when you taper the prednisolone, then you have to add the aspirin.
I wouldn't
Yes.
start
But you have
aspirin.
not
This
mentioned.
was
Yeah,
during
yes,
hospital stay, ma'am.
yes.
This was during
Yes,
at the
mentioned.
time of discharge, ma'am.
Madam,
We are
for
coming
this,
to it, ma'am. We
for
are
this,
coming to it.
yeah, I'm just coming to
Go
it.
to the previous slide.
I'll coming to it. I'll
Previous
complete that, madam. I'll also answer that point. That
Okay,
one.
sir. Okay, sir.
I'll come to that. I'll come to that. Now, where did I leave? Yeah. Now, India is becoming a low endemicity country. You know, in high endemicity country, for recurrence, even arthralgia or monoarthralgia or monoarthritis should be considered as one of the clues to the presence of rheumatic fever. But India is becoming a low endemicity country. That's one. Second is the peculiarities of some manifestations of rheumatic fever have to be kept in mind. Very importantly, chorea, rheumatic chorea. Rheumatic chorea is one disease which most often occurs without arthritis or carditis. Arthritis or carditis. But the point that you must remember is that rheumatic chorea, though it is usually an isolated manifestation, it can come, arthritis or carditis can come before or after or coexist. So every child with rheumatic chorea should be given penicillin prophylaxis following rheumatic chorea. That's point one. Second is
After
rheumatic
excluding
chorea.
other causes.
Rheumatic chorea alone is enough to diagnose rheumatic fever. No other major criteria or minor criteria
No criteria need to be fulfilled.
Yeah,
Right.
that's one. Third point, in the Jones criteria, the recent modifications, instead of ASO and throat swab culture, they have also included rapid streptococcal antigen test as a diagnostic confirmatory test for preceding streptococcal infection. The reason why I am stressing is I personally have kits for strep throat. Abort kit is there. I do routinely all throat swab following the McKissick score. And it's a simple test. It costs only 250 rupees. You can diagnose streptococcal infection. That is included as one of the evidences for preceding streptococcal infection, Jones criteria. That's it. Coming to the treatment part, few changes have taken place. Madam is talking about aspirin. In this patient with severe carditis, I would not be giving aspirin at all initially. Now it's all, even in mild carditis, aspirin is today replaced by naproxen or ibuprofen because of concerns for safety and adverse effects. So now, after all, you must remember aspirin has no effect on the heart. It's got effect only on the joints. In fact, NADAS, I still remember mentioning, it is difficult to believe that aspirin, which has got such a fantastic action on the joints, does not act on the heart, but it doesn't act. So for carditis, there's no point in giving aspirin. And arthritis is never going to be chronic. It's never going to be incapacitating to the individual. In fact, though there is a type of arthritis which is described as Jacquard's arthritis, where in rheumatic fever you can have, destructive arthritis.
Yes.
Last is what is read in the literature is that in the West, they don't see any more rheumatic fever. They don't see any more rheumatic arthritis. What they see more often in the West is post-streptococcal reactive arthritis, which is one of the differential diagnoses of any arthritis. This post-streptococcal reactive arthritis, you may have ASO elevation, you may have anti-DNase elevation, and you will not get large joint arthritis, you may get minor joint arthritis, you may have persistent arthropathy for quite a few weeks, unlike the fleeing, migratory polyarthritis or rheumatic fever. The diagnostic clues are, in post-streptococcal reactive arthritis, carditis has been reported, but it is very rare. But there is a lot of controversy in literature whether children diagnosed with post-streptococcal reactive arthritis should be given penicillin prophylaxis or not. Last is, other than chorea, the other post-streptococcal neurological manifestation is PANDAS, post-streptococcal autonomic neuropsychiatric
Disorders.
disorder. That also the
Streptococcal
name has been
meningitis.
changed to CANS. It's no more called PANDAS. It's called CANS.
Yes.
Okay, that's a recent term which can follow streptococcal infection. I sorry, I'm not getting the expansion for CANS. Some of you younger can find out from the net. It's called CANS. It's no more called PANDAS. The term is gone. Post-streptococcal neuropsychiatric, they present with tics. ASO may be high. Okay, and you give penicillin or amoxicillin to eradicate. Right? Last is your rheumatic fever. In addition to following impetigo or sore throat, may also follow scarlet fever, which is on the rise today. But I don't know, we are not seeing much of rheumatic fever these days. I hope with the increase in number of cases of scarlet fever, the number of cases of rheumatic fever does not go up. Okay, these are my comments. Dr. Lasyasvi,
Yes, sir.
you presented very well.
Thank you, sir.
You did extremely well. If I were your examiner, I will give you distinction. Thank you. God bless you. Over to Dr. Ramakrishnan.
Right.
So
A
childhood
few words.
acute
Thank you, sir. Thanks for the
neuropsychiatric.
compliment. Yes. Tell something. You're telling
Childhood
something?
acute neuropsychiatric syndromes, CANS.
Pardon? Pardon?
Childhood acute neuropsychiatric syndrome.
Okay. Thank you. Because old age, I can't remember too many facts.
Right. Thanks for the compliment, sir. One thing is benzoyl penicillin primary prophylaxis and secondary prophylaxis. Primary prophylaxis to clear the streptococci from the throat, and secondary prophylaxis to prevent the recurrent infection and recurrence of rheumatic fever. And for infective endocarditis, when there is dental caries, we have to give prophylaxis, even though the child is on benzoyl penicillin, because the MIC attained with benzoyl penicillin will not be able to prevent any other infection excepting the recurrence of this throat infection because of GAS. Okay, digoxin we started, and specifically knowingly well the digoxin role is going out of vogue, but the pediatric cardiologist insisted that shall be continued. And what are the effects that are qualified pediatric cardiologist from UK, and what are the things that were, doesn't mean that he is from UK, everything is fine, but just I'm telling. And the effects we wanted is inotropy, lysotropy, and decrease in the preload, that is by fusimide, and decrease the afterload by which one? Enalapril. And cardiac remodeling, that is done by enalapril. Prednisolone is for carditis, and cardiac, we want lysotropy is better with carvedilol. Okay. Right. Next slide.
Okay. Dr. Ramakrishna, I think it's going to be 11. My
Yes,
battery.
sir. Last slide.
Down.
This is last slide.
Time for
Yes,
us
sir.
to congratulate.
Yes, last slide.
To see Datta and finish it, sir. Thank you. My battery is also down. It's going to be 11. Thank you very much.
We'll call it a day, sir. It's over. It's over. Right. Next slide. Last year.
Final diagnosis.
Okay. We discussed already. Don't worry.
Right. Next.
Any more? Yeah. Thank you. Well done. My compliments to you. My blessings to you. Over to the moderator, Dr. Ramakrishna. Thank you. You can switch off the slides. Thank you.
Right. Yeah.
Thank you so much.
Unshare.
Thank
Stop
you for your
sharing.
slides.
Thanks, Dr. Bala, SBS, sir. We fondly call Dr. Bala, and for your lucid, analytical case discussion with your rich experience. And Dr. Lasya, you presented well, and wish you all the best for your career. And you don't say about exams alone. And
you can stop the slideshow. You can stop the.
You can stop. You stop sharing.
Yes.
And I feel happy to see the more important than the PG, more than the PGs, it is Dr. Alok Gupta's, Dr. Kalpana Datta's, and Dr. Pramod's. Right. The seniors are more interested in these things. The people for which it is targeted are not Dr. Chaudhary Babu. All these are professors. And we are really happy that they have participated also. Dr. Vijay Lakshmi, Dr. Usharani. Most of the professors participated rather than the PGs. Right, sir? Thank you very much. And we are very much enriched with your presence. Thank you, sir.
Thank you.
We'll get good night to all.
Thank you, sir.
Thank you. Good night. Well done. God bless you.
Thanks.
Dr. Saji, we'll close it. Mr. Saji, we'll close it. We'll call it a day.
Yes, the closing, sir. In a minute, sir.